Hello and welcome to this video on enhancing referrals and management of MUO and CUP patients. We do hope that you find it useful. Please share your thoughts in the comments and make sure you like and subscribe so that you don't miss any new content that we upload. Now, before we hand over to Sarah, it is my pleasure to introduce John Simons, who's the Director of CUP Foundation. Hi, John.
Hi, good morning, Hope. Thank you very much. And good morning and welcome to all our participants. I'm just going to share my screen. An amazing number of people we've got registering today, 246, which is tremendous. So welcome to you all. My name is John Simons, and I am the Director of the CUP Foundation. And I'm just going to show you about 2 slides before introducing Sarah. The next hour is about service development, improving diagnostic and treatment pathways, getting a sense of the CUP trials that our expert speaker, Sarah Ngan, is involved with. So before introducing Sarah, I just want to share with you one big picture slide to put things in context. The slide shows 2 very different decades. The first box, where CUP was largely an inconvenient truth. Diagnosis and treatment was largely ad hoc and widely recognized as suboptimal, with patients bouncing around different MDTs before they died. This started to change with the introduction of the NICE guideline in 2010, a very significant year for us, which is when CUP becomes a diagnosis in its own right, rather than a failure of diagnosis. CUP patients since 2010 have a treatment pathway based on evidence in the same way as any site-specific cancer. Numbers are now falling. In fact, they have been since 2007. Incidence and mortality rates have dropped by 1/3 in the UK, which is pretty impressive. In fact, it's the fastest decrease in incidence in terms of all cancers. And this has really resulted from not just the NICE guideline per se, but also those of you working in AOS, MUO and CUP teams, bringing to bear your expertise on this challenging diagnosis. But it remains a huge problem for the NHS, with some 57% of patients presenting as an emergency. We are entering a very exciting time where the science is accelerating, allowing patients on trials to have treatment based on diagnostic tests to identify the molecular primary or the molecular target. The value of immunotherapy treatment in addition to or instead of chemo is currently under investigation. And there are tests that can be performed to predict a patient's likely benefit from specific treatments. The days of chasing the primary are drawing to a close, but we are some considerable way off from these advances becoming standard of care. Sarah will be touching on the bullet points in the second box. She is a consultant in medical oncology at Guy's and St Thomas's, where she is the clinical lead for acute oncology and CUP, and the network CUP lead for the London Cancer Alliance. Thank you very much, Sarah, for giving your time today to lead this session, which I'm sure will include valuable learning also from participants joining in the Q&A. Just before I shut up and pass you to Hope to manage the session, let me give you a 10-second commercial, and this is to advertise the patient decision aids which we developed with Sue Ryder, in case you don't know about them. This slide shows the range of PDAs, And if you don't use them, please find them on our website. And it would be great to have feedback if you do use them. And hopefully they will prove valuable for your patients. They can be found on our website under treatment. Now let me hand you back to Hope.
Hi, John. That was brilliant. Thank you very much. And a wonderful introduction to Sarah as well. So I will hand straight over to you, Sarah.
Good morning, everybody. Thank you very much, John, for your introduction, and also for Hope and Daisy for inviting me to speak and host the seminar for today. As John has said, I'm one of the medical oncologists. I'm based at Guy's and St Thomas's Hospital in London. I'm the service lead for the Cancer of Unknown Primary team, has been involved in AOS for quite some time, and also the pathway chair now for the South East London Cancer Alliance. What I want to really talk with you about today is really how our service at Guy's and St Thomas's functions, how it's evolved now. It's been established for nearly 10 years, and what learning I've had and the rest of the team have had along the way. I'd like to present as well a challenging CUP case with some learning points, and would really encourage Q&As at the end, inputting into that, and how we can continue to do things better for our CUP patients. As John has said, I'm going to do a brief review of where we are regarding clinical trials and an update on current recruiting UK studies for cancer unknown primary patients. And then a little bit of reflection at the end in regards to the COVID pandemic and the effects that that has had on the MUO CUP services, what the challenges have been, what the challenges of future waves may be, and what opportunities those have bestowed upon us as well. And if we have time at the end and people would like, I can basically go through another challenging case as well before heading on to the discussion. So the Cancer of Unknown Primary service was established nearly 10 years ago now. And as John very eloquently said, it really came about as a result of the NICE guidelines, which came out in 2010. And then the National Cancer Action Team peer review measures, which came out in October 2012. And these guidelines and measures really gave the infrastructure and the impetus to basically change the way CUP patients basically managed, to make sure that there is interdisciplinary team management of these patients with key worker support, as very much patients in other tumour types were basically having. So I think what was extremely helpful from the NICE guidelines was that they very nicely really described and broke down CUP as a disease spectrum, using definitions of which some of you may be familiar with and others not so much so, but just to really remind everybody that the CUP is really a spectrum of patients who have an MUO, where they've been diagnosed with a probable metastatic malignancy on the basis of limited number of tests, to basically patients who've then had further investigations, primarily cross-sectional imaging and histology, and a clear primary hasn't been identified, to patients with confirmed CUP or C-CUP, who've got a metastatic malignancy, which cannot be, primary site can't be identified despite specialist review and further investigations. So, as always been mentioned, the incidence of CUP worldwide, it incorporates about 2 to 5% of new cancers. That incidence is falling, primarily, I think, as has been discussed, with the advent of AOS CUP services, and improved, I think, immunohistochemistry in order to diagnose the primary sites. However, it is still a very significant problem, particularly since these patients often have very advanced cancers. And as John has said, 57% of CUPs are diagnosed as an emergency presentation, versus 23% of other cancers, which is where I think the interface between AOS services, MUO services and CUPs are so important. Historically, the survival for these patients has been very, very poor. Reassuringly, the survival is beginning to improve, but the prognosis for a lot of these patients has a median survival of often less than a year. And I think that the problems with really these unfavourable CUP patients, and I'll talk a little bit in my subsequent slides about how CUP patients are characterised, is that response rates to classical chemotherapy, platinum drugs are very, very poor, with median overall survival in trials which have been done 4.3 to 11 months. It's really important for these patients to inform patients of the benefits and risks of embarking on empirical treatment, and also really important to consider clinical trials for these patients. So at Guy's and St Thomas's, we're very lucky in that we have what we call a standalone CUP MDM. We're not part of another site-specific MDT. We work as a local CUP team where patients with metastatic malignancy of undefined primary origin are initially referred, and the majority of these patients are come from the AOS team, and the AOS team at Guy's and St Thomas's reviews these patients on the wards, usually within 24 hours of referral from a Monday to Friday, and also acts as a specialist CUP MDT to which further groups of provisional CUP cases are referred for further advice on diagnosis and management from both Guy's and St Thomas's, but also from our network hospitals across South East London. I think that over the last really 10 years, we were reviewing a substantial number of these MUO patients within our MDT who have been referred from the AOS team. I think the AOS teams and the site-specific MDTs are now more used to dealing with these groups of patients, and actually our referrals from AOS have reduced quite significantly. The majority of the MUO patients who we now see tend to be patients who have no, I guess, home team. So they tend to be often from the skin MDT, where patients are diagnosed with a metastatic malignancy from a skin biopsy, and also from the orthopedic team, where patients are diagnosed with only metastatic disease. Tend to basically be the significant proportion of patients who are now being referred on to us. So the way basically the team works is, I say, trying to basically target investigations to confirm treatable disease for MUO patients and hopefully identify a primary site. And for patients who have a provisional CUP, basically work those up, and if a confirmed CUP is diagnosed, try and select patients who've got treatable syndromes or the favourable subsets and refer them on to the relevant specialist MDT, which I'll talk about further on for further management, and then management of the confirmed CUP patients using a mixture of palliative care and oncology support. So this is a little slide really showing our pathway. The aim of the pathway is really to stop at each step of the pathway investigations for patients who either don't want any further investigations or who aren't fit for further investigations and further treatment, to really streamline the pathway with early oncological input, and most importantly, I think specialist nurse support and palliative care support for these patients, to help them understand the diagnostic pathway, and to basically give them a key point of contact throughout the process. So we tend to find within our MDT in practice that by and large the MUO patients, as I say, the numbers who are referred to the local MDT are reducing, but with the MUOs which we are referred and the provisional CUPs which we are referred, we usually identify the primary or in about 80% of patients, or we basically keep them as an MUO or a provisional CUP because further investigations are just not felt to be appropriate. And then about 20% of our patients within the MDT will go on to have a diagnosis of a confirmed CUP, and then we will then try and delineate and select patients who are in favor of a favourable subset, which are around 20% of patients. But however, the majority of patients unfortunately fall into this unfavourable subset group. So as far as the diagnostic workup for the MUO provisional CUP patients, so mandatory is a CT scan, which usually detects the primary site in 30 to 50% of cases, and then also tissue, so pathology and a good immunohistochemical workup. So as an oncology trainee, when I first became a consultant dealing with basically CUP patients, I think the world of pathology and what they actually did was slightly alien to me, and I've gained a lot since being service lead for the CUP service and working very closely with our pathologists to understand a little bit more about how pathologists look at the histological specimens and how they basically then go on to narrow down what the potential diagnoses are. And one of our histopathology colleagues who basically works with us in the CUP MDT has provided me with really this slide, giving a little bit of an idea of how they basically approach patients with metastatic cancer. And I think the key thing is not only just the various histochemical stains, which our histopathology colleagues can do, it's really correlating the clinical case, correlating the radiology with the pathology to basically hone down what further investigations are most appropriate in order to try and identify a primary site for patients. So as you can see here, the first thing to consider that the pathologists consider when they're looking at any of the histopathological samples, see in the wrong direction, are to exclude non-epithelial tumours, so lymphomas, melanomas, sarcomas, germ cell tumours. And then for those patients who the immunostains suggest a likely epithelial malignancy, then working those up further with further immunohistochemistry to try and define a little bit further where the primary site of the tumour may be. But it's really working together with the pathologists and the radiologists and the clinical context of the case, I think, is basically where the MDT has really evolved over the last 10 years now. And we tend to now are able to identify by looking at the immunohistochemistry, the pathology, the clinical details, and the radiology where the primary site of the tumour is. So I think the other areas of or investigations which we sometimes consider are PET-CT scans. So PET-CT scans aren't a standard investigation to delineate a primary as defined, as recommended by NICE. However, in clinical practice, we do find that there is an indication in patients who have isolated cervical lymph nodes, since they may have potentially treatable head and neck cancer, and PET-CT scans are useful in this situation. Also in clinical practice, we found that in MUO patients where we're having problems in getting tissue, actually the PET-CT scans can sometimes be helpful in trying to target a site, best site for a diagnostic biopsy. Then depending on the clinical case, mammography and breast MRI is sometimes useful. Endoscopy, if patients have iron deficiency anemia or who have significant GI symptoms. And then tumour markers, we tend not to basically use routinely, although many of the patients who are referred to the MDT have had a panel of tumour markers done already, but they are useful in patients who we're concerned may have a germ cell tumour, particularly AFP and beta HCG, and also PSA in patients who have got mainly blastic bony metastatic disease. And then more recently, as part of the diagnostic workup, part of the ESMO guidelines now is to use LDH of which in patients who have a high LDH, it's useful in stratifying them regarding not as good a prognosis. And also there's some emerging evidence of using neutral lymphocyte ratios and CRPs as a prognostication for patients with cancer of unknown primary as well as other cancers as well. So as I say, once we have identified a patient as having a confirmed CUP, it's really then trying to see whether any of those confirmed CUPs fall into the subset of treatable syndromes, of which if they are treated as a potential, for instance, a site-specific malignancy, tend to do a lot better than being treated with empirical treatment. So for instance, somebody with upper cervical lymph nodes with no other lymph nodes elsewhere, even if on endoscopy, endoscopy, there isn't a clear head and neck primary, if there's no other sites of disease, if they're treated radically under the head and neck team as a head and neck primary using head and neck primary treatment protocols, they do a lot better than basically treating them with generic empirical platinum-based chemotherapy. And that is the same with patients with axillary lymph adenocarcinomas involving axillary lymph nodes, involving the breast MDM, squamous cell carcinoma in the groin, of which are treated radically with our colorectal colleagues, poorly differentiated carcinomas with a midline distribution if they're treated as a germ cell tumour, women with predominantly peritoneal adenocarcinoma treated as a gynecological malignancy under the gynae MDT, on poorly differentiated high-grade NETs are looked after by the neuroendocrine MDM. And then patients with solitary metastatic disease, some of these patients, if treated radically, for instance, with isolated liver metastasis or an isolated lung or bone lesion, we do sometimes seek advice from other MDTs as to whether radical treatment is appropriate. And then more recently, there's been 2 new identified treatable syndromes for these CUP patients. So patients with blastic brain metastases and with immunohistochemistry or suggestive of a prostate cancer or a high PSA, if they're basically treated as a prostate cancer by the urological MDM, have a better prognosis, and as well as patients who have a colorectal phenotype on their pathology, so CK7 negative, CK20 positive, and CDX2 positive patients, if they're treated as a colorectal cancer, again, are a favourable subset of CUP patients. And for these patients, we actually look after them in the CUP MDT, since our other hat, my other hat, and the other hat of the rest of the team is GI oncology. So that really leaves the unfavourable subset, which is really the remainder, 80 to 85% of these patients. The majority of these patients are have adenocarcinomas, 20% undifferentiated carcinomas, 9% neuroendocrine tumours, and 3% squamous cell carcinoma. So what have been the challenges for our service over really the last 10 years? Has it been a bed of roses? Is all harmonising well, or has it been a bit of a minefield? I think when we set up the service, there was definitely a lot of challenges. There was a historical MDT tennis was going on. It felt very much like the CUP MDT was the final person as the jury makers in the CUP pathway, trying to basically say, no, this patient should be a lung cancer, no, this patient should be a colorectal cancer. And there were a lot of comments from people from outside the team, which were a bit of a red flag to all of us in regards to how they perceived CUP and how they perceived CUP patients. And I've listed some of them now. I think over the last 10 years and how things have evolved, I think that it's all about building relationships. And I think those relationships have really evolved and improved over the last 10 years and have made the functioning of the team much better. So I think what have we got right? So I think within the MDT, our relationship within the MDT now works really, really well. So our MDT coordinator knows that for every patient who's referred, we need to have a referral form with all the clinical information, including performance status, what histological tests the patient has had, what investigations the patient has had, and all of that needs to be made available before the MDT. We're lucky within the MDT, we have obviously a dedicated pathologist and radiologist, and they update the team in between the MDT with investigations via email and phones, and also the depth of interest of our pathologists and radiologists is really helpful. I think that the role of the AOS CUP CNS now is very well established in giving patient information, basically telephone monitoring, keeping the patient up to date. And at Guy's and St Thomas's, we're very lucky in that we have an acute oncology assessment unit, which is open 7 days a week. There's a telephone triage available for advice for patients if they're developing symptoms, and is also available for face-to-face review of patients who are becoming more symptomatic on their diagnostic journey. And then we are lucky in that we have a palliative care consultant who works with our community team, as well as doing palliative care clinics at Guy's, who's very involved with the CUP team, and we often do joint inpatient reviews and reviews in the outpatient clinic as well. We have two medical oncologists and a clinical oncologist who are part of the MDT, so there is consistency within the MDT. There is adequate cross cover. I think it's quite helpful to have to be able to bounce thoughts and ideas off each other, and very helpful to have a clinical oncologist within the MDT who can give advice regarding palliative radiotherapy for a lot of these patients. We have 3 clinics per week. I think we tried to make one of the clinics a dedicated CUP clinic, but actually I think the flexibility of having 3 clinics and the ability to schedule patients according to when the investigations come in has been really, really helpful. We screen all referrals before the MDT, and often if patients require investigations before the MDT, we basically will contact the referring team to make sure those are done, and also if it's felt that the referral isn't appropriate for the MDM, redirecting them to an MDT to prevent a delay in then onward diagnosis. And within the MDT, we have video links with our acute oncology network teams, and so they present the network patients who have been referred to the MDT from the network. I think it is really, really helpful to have the CNSs dialing into the MDT to give live information regarding the status of the patient, the investigations that they've had, their performance status, and what their needs are, and I think works very well as an educational tool and an immediate point of contact. Obviously, building relationships with our patients is also very important. I think that both in the MUO and the CUP pathway, I think we're now very au fait with discussing with patients the appropriate of investigations, whether biopsy or not is appropriate, giving them clear contact information and really educating them about the importance of early palliative care involvement as well. So I think that the other key thing is relationship with other teams. So I think that we do have challenges with our diagnostic services, particularly interventional radiology. And I guess in the Q&A session, any input from any other teams who've really cracked this would be very helpful. Bronchoscopy, EUS, and endoscopy as well can be challenging. I think we have good contacts within the respiratory and gastroenterology departments, but there are significant waits still for patients to have endoscopic investigations, obviously not helped more recently by COVID. We've got good links with our site-specific now MDTs, and the coordinators, and it's very much about educating as well these MDTs about the importance of the role of interpreting immunohistochemistry in a clinical and radiological context, and that there are increased treatment options for probable primary tumours rather than basically labelling patients with CUP. There aren't any magical, other than clinical trials, there aren't any magical empirical treatments which are going to be superior than a probable primary treated by a site-specific team. So I think the other thing which we have improved on is our relationships with referring teams. I think now most of the doctors who refer to us know that patients must be informed of their probable cancer diagnosis for basically referral to the team, and that the minimal diagnostic investigations for MUO patients would be a CT scan, and for the provisional CUP patients a CT scan and a tissue biopsy. In addition to that, I think that the interface between the CUP AOS services is now very embedded. The AOS service provides a fantastic, very responsive service for inpatient review presentations and making early escalation decisions and involvement of palliative care. And the MUO outpatient clinic also helps for the earlier discharge for these patients, since they have a clinic to come back to get diagnostic investigations. And I think that the service has also enabled patients to be recruited more into clinical trials. And more recently, we have been fortunate to develop now a very good relationship with our RDAC clinic, which has been established at Guy's now for a number of years. So for people who maybe are not familiar with this, is the rapid access and diagnostic clinics have been really spurred on secondary to the ACE programme, which was developed by CR UK, Macmillan and NHS England. These multiple diagnostic centre models, where patients with vague symptoms are basically referred to, have really picked out about 8% of cancers, and have also helped to diagnose serious non-cancer conditions. And the aim from NHS England is that by the end of 2019-20, there should be one of these RDCs per Cancer Alliance to help patients with non-specific symptoms, and also to help a cohort of patients with site-specific symptoms who are currently served by an underperforming two-week pathway. So the RDAC service at Guy's and St Thomas's has been established since 2030. They've got a capacity for 30 new patients a week, and the service is run by an internal medicine geriatrician and physician, and also a medical oncologist with A&P support as well. So the RDAC clinic has really helped, I think, primary care have a point of referral for patients who they're concerned may have cancer or a serious condition who aren't served by a standard two-week wait pathway. And we've been working quite closely with these patients, with the RDAC clean, really helping them with patients where the cancer is not immediately obvious, and also providing symptomatic treatment for these patients as well. So I'd like to basically move on to where our challenges now are evolving into. So I think that the main areas within our MDT which we find difficult are continue to be people who, or patients where getting tissue, diagnostic tissue remains an issue. Patients with predominantly bone metastasis and also undifferentiated carcinomas. I'd like to share with you a clinical case which we had quite recently, which really highlights the fact that although I think services, MUO services are transforming and really streamlining the pathway for a lot of these patients, there are some patients who their diagnosis remains a challenge. And I think that there are still lessons to be learned and still improvements that we can make to this patient's pathway. So the clinical case I want to discuss today is a 45-year-old female who was referred from one of our AOS network hospitals, whose diagnostic pathway was more than 90 days. So in July of last year, she basically presented to A&E with a three-day history of problems with coordination in her left hand, tripping over, and some intermittent frontal headaches. Her performance status was 0. She had no significant past medical history. She was a professor of English literature, was a non-smoker, drank occasional alcohol, had a family history of hypertension, and nothing significant on examination, including neurological examination. The diagnosis at that point when she presented to A&E was a possible TIA. However, unfortunately, a CT brain at the time showed a 30mm hemorrhagic lesion within her right parietal lobe with some mass effect. And a subsequent CT scan showed multiple pulmonary emboli, bilateral, relatively small low lobe lung nodules, and this large pelvic mass, approximately 13 centimeters, involving the iliac vein and causing a thrombus. And the ovary wasn't completely separated from the mass. It was displacing the uterus. It was very difficult to identify where the primary, where this mass was arising from. In light of the hemorrhagic brain metastasis and pulmonary emboli, she had an IVC filter fitted, and an MRI confirmed a hemorrhagic, what looked like metastatic deposit within the right parietal lesion, but no other focal bone lesions. So the differential diagnosis at this point was a metastatic pelvic sarcoma or primary gynecological malignancy with solitary brain metastasis. She was appropriately referred to the neurosurgical MDT on the basis of the CT scan, and they felt that she had a solitary parietal metastasis, and they were very happy to consider stereotactic radiotherapy once the primary had been established. They referred concurrently to the gynecological MDT and had a pathway upgrade to gynecology, and was also referred to the regional sarcoma MDT. In the interim period, after discharge from a short admission, having presented to A&E, she then re-presented with a tonic-clonic seizure, and a CT scan showed extension of the hemorrhagic component of her brain metastasis. At that point, the AOS CUP team became involved. She was reviewed by one of the AOS consultants on the ward, and the AOS CUP CNS began really tracking the patient and was actively involved in monitoring their symptoms and updating them with her diagnostic pathway. So on the basis of the CT, she had an MRI which showed that the right ovary wasn't identified separately from this right heterogeneous mass. It was very difficult to see where it was riding from, but it didn't appear to be arising from the uterus. And the sarcoma MDM triage, their outcome felt that it was most likely a gynecological primary, and so advised to proceed with biopsy under the gynecological MDM. So she went away and then came back on day 30 of her pathway and had a biopsy of this left pelvic sidewall mass, which unfortunately showed just necrotic tissue and was non-diagnostic. She was then re-reviewed in the gynae MDT, and they felt that the lung lesions were very difficult to access from a radiological perspective, and so referred to the lung team. The lung team felt that her case was quite complex, and so they didn't want to make a decision regarding biopsy until referral to the lung MDM, which is the fourth MDM she was referred to, where they felt that an IR-guided lung biopsy should be attempted, but rather be done locally. They felt it would be most appropriate for her to be referred to the cancer centre for this. In the meanwhile, whilst awaiting for the lung biopsy, she then re-presented on day 50 of her pathway with urinary retention, fecal incontinence, and right-sided sciatic pain, symptoms of compatible with caudal equina syndrome. An MRI of her whole spine unfortunately showed significant disease progression over the preceding 6 weeks, with the pelvic mass now enlarging and infiltrating into her nerve roots. She was discussed at the MSCC MDM, which was the 5th MDT she was discussed at, and she was becoming more symptomatic, and so began to have some very good palliative care input on the ward. In the meanwhile, being supported as an in and outpatient by the AOS CUP CNS, and had some pelvic radiotherapy to the mass in order to help with her symptoms. She eventually, on day 59, underwent an IR-guided lung biopsy, and the histology was provisionally reported as a malignant tumour with a rhabdoid morphology. It underwent extensive immunohistochemistry by the local pathologist, and they felt that there was a wide differential diagnosis, including, and sarcoma at that point couldn't be excluded. So the case was sent to the Royal Orthopaedic Hospital in Birmingham for a further expert pathology opinion. In the meanwhile, however, the sarcoma, regional MDM felt it was unlikely, on the basis of the information that we had, that it was going to be a chemosensitive sarcoma, and it was probably best to be treated as a carcinoma. I think at this point, on day 80, or just before day 80 of the pathway, the local, I think, AOS team were really struggling with where this patient should go, and they asked for our specialist opinion. And whilst waiting formal review from Birmingham, we reviewed the clinical case, and we reviewed the patient clinic with a partner, with the patient's partner. At this point, her performance status had deteriorated to 2. She had some worsening left-sided weakness and some new subcutaneous skin deposits. And it was really at this point we were able to help tie everything, well, tie as many things as we can together for the patient, explaining that she had a poor prognosis tumour and may not be fit for further treatment, and that it may not be advisable to wait for the specialist's opinion from Birmingham, and we may be best as cracking on with chemotherapy and treating her as a CUP tumour. In light of her new symptoms, she had a further MRI brain scan, which showed marked progression of her brain disease, with multiple new enlarging hemorrhagic brain lesions, edema, and significant midline shift. And our CT scan showed that despite her IVC filter, she had significant now bilateral pulmonary emboli with enlarging pulmonary metastasis, new right-sided hydronephrosis, secondary to further progression of her right pelvic sidewall disease. I think when we basically saw it in clinic on the 29th, over the preceding 48 hours, she was in contact with the CUP CNS and also our acute oncology assessment unit triage team, and there was a lot of concern that her symptoms were worsening. And so we were able to review her on the acute oncology assessment unit with her partner, where her performance status had reduced to 3. She'd had a further seizure. We had an opportunity for a symptom review and felt that she was probably going to be unfit for systemic treatment. And Nicola, who I hope is on the webinar today, he's our CUP AOS CNS, will remember we had a very, very sad and complex discussion regarding all the diagnostic tests she's had today, underlying prognosis, and had a very frank discussion with her regarding next steps, and whether or not, with the background of COVID, whether she would like to be admitted in order to optimise her symptoms, of which, after a lot of discussion, she decided she would like an inpatient admission, and sadly, she died on day 88 of her pathway 4 days later. And subsequently, on the 28th of October, we eventually got the histology report back from Birmingham, which showed and they felt that she had a poorly differentiated non-small cell carcinoma with rhabdoid features, most likely metastatic, most likely arising from an ovarian carcinoma, but recommended further tissue. So I think a number of learning points from this case. I think that, as you can see, that these patients with complex diagnostic pathways and issues in obtaining tissue can be very, very difficult. Despite the establishment of CUP MDTs, these multiple MDT inputs can lead to delays. And I think the biggest learning point was really to encourage earlier referral to the CUP MDT for these complex MUO patients. I think the other learning point is for these poorly differentiated carcinomas who require a complex histological workup. I think we do need to try and improve this pathway for these group of patients. I think there's a lot of concern that there could be that these patients could be sarcomatoid type tumours, and it can lead to anxiety in actually starting empirical treatments for them. And I think this would be a good area for a national audit. I think what it does show, however, is that, that flexibility of your service is very important. We were able to review this lady very soon after she was referred to our MDT. We were able to get her up to our acute oncology assessment unit very rapidly for a symptomatic review and for a case discussion. And I think the key thing is that the regular contact with the AOS-CNS across her diagnostic pathway to update her on the results of each of the MDTs did make a difference to the patient, and also after the patient passed away, providing bereavement support to the family as well. So moving very quickly on to I think clinical trials for CUP. So the main themes regarding clinical trials can be really divided into 4 sections. So empirical chemotherapy, diagnosis of tissue of origin, next generation sequencing to identify actionable mutations, and immunotherapy trials using checkpoint inhibitors. So chemotherapy studies, essentially, to keep a very long story short, there have been multiple phase 2 studies and a recent meta-analysis of 543 patients with unfavorable CUP subsets, and none of these have basically shown a single treatment regime has had any significant benefit compared to any others. And as a result of that, as part of the ESMO clinical practice guidelines, there are a wide range of mainly platinum containing regimes, which are recommended for patients with confirmed cancer of unknown primary of unfavorable subset, with no regime showing superiority over another. So the next area really of CUP trial investigation is site of origin tests, really seeing how the genetic and molecular profile of the tumour is, how similar it is with common tissues, common cancers of known origin. And these are really RT-PCR based arrays and microarray tissue of origin tests. So in summary, there have been four larger trials looking at using tailored therapy, using tissue of origin tests, comparing with empirical chemotherapy. There have been 2 non-randomized studies which were done which were done up until 2015, which looked very promising. They were regarding improved median overall survival for tailored treatments compared to empirical treatments. However, the first randomized controlled trial undertaken in Japan, trying to answer this question, didn't show any improvement in overall survival between tailored treatments and empirical treatments. And more recently, a trial out of Europe, which has been the largest randomized phase 3 trial, has again, unfortunately, not shown any improved survival of empirical treatment compared to a tailored treatment approach. And given that this trial was recently discussed in ESMO 2018, I thought I would just give you a very quick overview of the Jeff Cappy study and what the results showed. So this was a study looking at patients with a confirmed CUP, of excluding patients from the favourable subset who hadn't had any prior treatments. Their performance status 0 to 2. So quite a real world experience, a practice. They were either treated with empirical chemotherapy or had a molecular test and a tailored treatment for a suspected primary. And just very briefly, the trial recruited between 2012 to 2018, and 110 patients out of 223 in the ITT analysis had empirical treatment and 113 had tailored treatment. As was seen from the previous trial, the PFS and overall survival showed no benefit. However, some of the tailored treatments were associated with better outcomes in suspected cancers poorly sensitive to standard chemotherapy, but the subgroups was too small to test. I think on reflection, I think one of the issues with the study was that actually a lot of patients who had tailored treatments had poor prognostic cancers. So they were mostly HPV or esophageal gastric cancers, where the overall survival it probably isn't that much different in the experimental and control arms compared to the standard treatments that we basically give these patients. So finally, as a result of this, both NICE and ESMO don't recommend the routine use of these tissue of origin tests. And then moving on really to next generation sequencing, looking at targetable alterations. So I think there's been 3 retrospective studies in CUP patients, 2 using NGS and 1 using circulating tumor DNA, which all really show that there are potentially actionable mutations using these technologies. And it's really the basis of this which has really spurred on the Capisco trial, which is recruiting in the UK. It's a phase 2 trial involving 8 centres, and it's really comparing the efficacy and safety of targeted therapy or cancer immunotherapy guided by genomic profile testing versus standard platinum-containing regimes. So just very briefly, the study design for this study, which, as I say, is open within the UK, is that for all patients who are suitable for the study, have 3 cycles of induction chemotherapy. They have their tissue and blood sent off for genomic profiling and selected biomarkers, including MSI as well as PD-L1. For patients who are responding, they're then randomized in a 3-to-1 arm to either an actionable mutation if they have one, and if they don't, they tend to continue with induction chemotherapy with the immunotherapy drug, and with the control arm being basically continuing with standard platinum-containing immunotherapy. And for patients who are non-responding, the investigator's choice of treatment following molecular tumor board advice as per the randomized arm. Finally, the other area of trial design is really immunotherapy studies. There's been a study looking at nivolumab in the Nivo CUP study, and within the UK there's the CUP-M study, which is a phase 2 trial of pembrolizumab in CUP, which is again open in the UK, looking at in patients who've had more than 1 line of chemotherapy. That cohort is now closed, but the second cohort, which is the use of CUP in first-line patients, is now still open. So very quickly, I guess, reflections regarding COVID and the impact on CUP MUO. I think one of the big challenges is this concept of stage migration, which has been documented for a lot of site-specific cancers. And at the end of the first wave of COVID, we did have an increased activity for our AOS teams regarding emergency diagnoses. And I think that this is important to consider in subsequent potential waves of COVID, particularly since a lot of the AOS CNSs were redeployed. The effect of reduced clinical trial activity has taken a long time to basically recover. And I think that the impact on reduced face-to-face consultations, all the way from basically patients presenting to their GP to having their diagnostic chest, has meant that symptom management hasn't been optimal for a lot of patients, nor appropriateness of investigations. And I think of concern as well is that the quality surveillance programme, otherwise known as peer review, is on hold again for 2019-2020. And although peer review historically has been quite painful for a lot of us who've been involved in it, I think it does help keep services to account in regard to making sure they're compliant with the measures recommended by NICE. I guess the opportunities that have come out of COVID are really improving patient communication, the role of video conferencing, and also data collection on late stage cancers, which may help us as well understand more of the biology of the disease for CUP. Thank you very much.
Thank you very much, Sarah. That was brilliant. So if I could just invite John back on screen and we'll go through some of the questions. So the first question is for Sarah. Do you have a 2WW for MUO Cup?
We don't.
Okay.
Not currently.
Thank you. The next question is
we upgrade all our patients onto a cancer pathway, and a lot of the patients now with non-specific symptoms basically go through the RDC clinic, which is classed as a 2-week wait pathway.
Brilliant, thank you. Sarah, this question is also for you. Can you tell us about your referral criteria to the CUP service and the MDT? And does the acute oncology service manage the pathway, or is it done by another team?
So I think that, I guess, 2 components to that. The acute oncology service manage the inpatient pathways, so any of our emergency presentations are managed by the acute oncology service, and then the CUP MUO team manage the outpatient service. As far as referral criteria, so we basically accept any patients who have got either a histological or radiological diagnosis of a cancer, who don't fit into another basically MDT for review at Guy's and St Thomas's. And then we basically also accept referrals from our network hospitals for patients who have had histology and imaging where a primary site is not obvious.
That's great, thank you. John, on your timeline slide, you show a vertical arrow from problem to solution. What are your thoughts on there being a solution to CUP?
It does, of course, depend on what one means by solution, but the short answer, I think, is yes. We're on the cusp of a paradigm shift in terms of cancer, moving away from cancer being seen as an anatomical disease towards cancer being a disease of the genome. But we're a long way from science to the bedside. If one was to ask Tony Greco, who's the US guru on CUP, he believes that using a combination of IHC and molecular profiling, that he can identify 85% plus now of CUP patients presenting, and identify a primary, if one goes back to the anatomical identification. He maintains that there will always be about 5% of CUPs in the future that will never have any resolution at all. There'll never be any understanding. But the answer, if you accept the move towards genomic science, is that gene expression profiling or looking for actionable mutations is undoubtedly the way forward. Sarah mentioned one of the trials, well, a number of trials, and I would just say that the Japanese trial comparing empiric therapy with gene expression profiling therapy or molecular profiling, the Japanese study has largely, well, by many people has significant flaws. It's not robust in its research methodology. The GEPCAP trial, actually, if one delves into that, the subsets of patients on that who were could be defined as in treatable subsets was actually very encouraging. But the overall, if you take the overall results, they were indeed poor. So yes, I think we're on the cusp of a really exciting period in CUP research, in the and it's starting slowly to be implemented where there is evidence to encourage change, to turn it into treatment of care. But that's for Western countries. In undeveloped countries or less developed countries, I'm afraid it's a long way from being a solution.
That's brilliant. Thank you very much.
I'd agree with John. I'd say that probably in clinical practice now, that within our MDT, about 80% of patients will get a primary diagnosed, having gone through the MDT and reviewing the pathology and radiology in the clinical context. We are getting less and less patients diagnosed with a confirmed CUP.
Great, thank you. Next question is, did I hear correctly that you do not routinely use a panel of tumour markers? If so, why?
Yeah, we don't basically find them particularly helpful. They're not recommended really on NICE guidelines either. I think they are helpful, as I said, for specific situations. So if you're worried about a possible germ cell tumour, a hepatocellular carcinoma, but in general, we have found that tumour markers aren't that helpful in really narrowing down a diagnosis.
Okay, thank you. How different is survivorship between favourable and unfavourable CUP?
So the favourable subsets, if they're basically treated as, for instance, the colorectal phenotype, if they're treated as a colorectal cancer, their prognosis is still not as good as colorectal cancers, but is improved compared to the unfavourable subsets. So, for median survival for the unfavourable subsets, as I said, it's anything between 4 and 11 months, whereas for the patients who, for instance, are a colorectal cancer who are treated as a colorectal phenotype, the prognosis can be up to 18 months, but not as good as patients who've got a known primary colorectal cancer. I think it probably just reflects the fact that these patients have got whatever the primary cancer is, it's a bad primary. It's just they have a bad type of cancer.
Okay, that's helpful. Thank you. This is a question for John. From CUP patients and carers' contact with you, what seems to be the main issues in patient care?
This has changed enormously since the introduction of the NICE guidelines in 2010. And obviously those have taken some time to be bedded in across the UK or England, Wales, Northern Ireland, because they don't officially apply to Scotland. Until they were bedded in, the main things we used to get were quite horrific about the standard of treatment, standard of care, lack of knowledge of oncologists. I mean, they were absolutely heartrending. But the expertise developed now through MUO and CUP teams is fantastic, and I hope that will improve the position for patients with the implementation of RDCs. Now, often get questions about procedures for getting second opinions. There are still people who are unhappy with the way they are being treated one way or another. But the one thing that always comes out as very positive is the role of the CNS, and that comes out in every study, in every environment.
Thank you. So the next question is, what pathways do you have locally to allow patients to be assessed as outpatients rather than needing emergency admission? Oh, and then they said, sorry, I think my question's already been answered. So I've already answered that one.
So I think for Guy's and St Thomas's, we have 3 oncology clinics a week, so we're able to basically review patients if they are getting worsening symptoms, and also we've got our acute oncology assessment unit, which is available to all our patients on the pathway if they're basically getting more symptomatic for an urgent symptom review. In addition to that, we've also got outpatient palliative care clinics run by our palliative care colleagues, of whom, if we're basically having problems with patients who are becoming increasingly symptomatic from either a pain perspective or problems with constipation or severe nausea, they're also willing to basically help symptomatically manage these patients too.
That's brilliant, thank you. So the next question is, Sarah, can you comment a bit more on the presence of MDT? We agree, and we're trying to get others aware of the need for a clinical oncology and radiotherapy opinion of these patients, but it would be good to have your advice about how to persuade SLT that this is a need.
I think looking at your data, I think is probably collecting the data which you've got, the patients that you're seeing within the MDT who would benefit from a clinical oncology opinion, and by not having a clinical oncologist in the MDT, potential delays in initiating palliative treatments for them. I think that's probably, data is the most powerful thing to try and persuade, I think, service development and taking service forward.
Thank you.
And I think the other thing is identifying somebody who's enthusiastic and has an interest potentially in CUP, because I think that if there is an individual who's interested, it's more likely that they will be agreeable and keen to get it incorporated into their job plan as well.
That's great, thank you very much. Would you explain if in the UK the pathology reports are documented nationally? If yes, do you think patterns of CUP are recognisable in the pathology reports? And how does a pathology report of a CUP patient look?
I think more recently there have been Royal College of Pathology guidelines regarding how basically the pathology reports for CUP patients should be standardised, on what the minimum immunohistochemistry for these patients should be. So I think in general, for definitely patients who are reviewed in a specialist MDT as a provisional CUP, I think that the immunohistochemistry and how they're basically reported is becoming more standardised.
Okay, thank you. We've got a few more to go through. I'll try and do the ones that have come in now, and we can leave it there. But do you guys in St Thomas's have a follow-up scan protocol for CUP patients?
I assume that is follow-up protocol as in when patients are on treatment and following treatment, I assume.
Yeah, it doesn't say.
Well, so for patients who are on treatment, we basically follow them up really probably with CT scans after they finish their chemotherapy every 3 months, or if they basically have new symptoms, we basically do imaging sooner than that.
Okay, thank you. Do you find barriers from neuro-oncology and surgery MDT for patients who have brain mets of uncertain origin and there's no other areas to biopsy?
Yes. I think that is an area that is challenging, but I think that if the patient is otherwise fit and there isn't any other site to biopsy, I think it's really communicating to the neuro-MDT the importance of getting a tissue diagnosis, particularly if the patient is potentially fit, and actually presenting the patient at the MDT, speaking to members of either other oncology colleagues who sit on the MDT prior to the patient being presented, and explaining why we think that the only way of obtaining tissue is a brain biopsy and the importance of that.
Okay, thank you. Any tips for educating GPs to refer to MUO clinics?
I think probably GP educational events are key. I think a lot of the time as well, that within an area there is often a Macmillan GP or who has an interest in cancer, and really engaging with them, and then subsequently being involved in GP educational events, I think really helps highlight basically the services, but I have to say that since the formulation of our RDC clinic guide, I think GPs really find it helpful. They definitely don't have problems with not referring patients to the service.
Okay, that's great. So final couple of questions and then we will call it a day. So how many patients does the CUP service see per week in outpatients? Are your 3 clinics per week purely?
Yeah, so we have 3 clinics a week, which are a heterogeneous group of GI and CUP patients. Probably new patients, it's become, as I say, we're becoming better at basically diagnoses. We're getting less MUO patients referred from AOS. So it probably is only about 1 to 2, maximum 1 to 2 patients per week that we would basically see with a new diagnosis.
Great. So the final question is, when a biopsy has been taken from the referring hospital, how often does the reassessment of the biopsy with additional IHC by the pathologist change the original pathology conclusion?
So I think a lot of the patients where the pathology is often it's not conclusive as to a primary site, and I'd say probably in 80% of cases where the pathology is reviewed in the context of the radiology, we are able to delineate a primary site diagnosis.
Okay, that's wonderful. That is all of the questions we've managed to answer. I'm ever so sorry that we've run over slightly, but I do appreciate you all sticking around to answer the questions. So thank you very much, Sarah, and thank you to John and the CUP Foundation for supporting the webinar.